I'm delighted this evening to welcome the fellows, members, alumni, and many friends of RCSI from North America, and indeed from around the world, with whom in ordinary times we would gather during the American College of Surgeons Clinical Congress, to renew friendships, to talk of times past and times to come, and to catch up on events in Ireland and the college. Sadly, we meet in virtual reality because of the COVID pandemic. I'm very grateful to the President of the American College of Surgeons and Honorary Fellow of RCSI, Dr. Valerie Rusch, who has kindly agreed to say a few words of welcome.
Good evening. It is my distinct pleasure to welcome you to the 2020 Clinical Congress of the American College of Surgeons. Like all other major organizations this year, we have had to frame shift rapidly to a virtual meeting. We have made every effort to retain the richness of the in-person meeting with over 1,600 presentations, including scientific papers, panel discussions, and named lectureships. In recognition of the impact of COVID-19 on the lives of medical professionals around the world, the registration to this year's meeting is free. Last year, I had the great privilege of being accorded an honorary fellowship in the Royal College of Surgeons in Ireland. I would like to thank the leaders of the RCSI for their warm welcome and their hospitality, and for allowing me to participate in this superb meeting. Hopefully, by this time next year, we will all have the opportunity to see each other in person. And again, I welcome you to the ACS meeting and hope that you enjoy our offerings.
Thank you, Dr. Rusch. When we lived in Minnesota in the early 1980s, turning on NPR, National Public Radio, on a Saturday evening to listen to Garrison Keillor narrate the weekly edition of A Prairie Home Companion was something we looked forward to. How sad you might think that we had nothing better to do, but the program did capture the values of family, community, and the small things in life that really mattered in the Midwest, a place that for a number of years we called home. In the busy world of the 21st century, COVID-19 has given us all a reality check, which may turn out to be one of the positives from this unfortunate period. A Prairie Home Companion came to mind because Garrison Keillor always started with the same phrase. It's been a busy week in Lake Wobegon, the fictional town where it all began. Well, it sure has been a busy week at RCSI. Indeed, it's been a busy year since we last met at the ACS Congress in San Francisco. In November last, the medical and health sciences schools in RCSI gained full university status, a cause for true celebration amongst RCSI faculty and students and alumni. RCSI was riding the quest of the wave and planning for future developments when word of coronavirus in Wuhan reached us. Remarkable foresight and planning facilitated early examinations and professional job interviews so that there were no interruptions in academic or career progression. Our investments in the National Surgical Training Centre and the modern facilities and IT systems in 26 York Street have proven invaluable in coping with the needs of medical education and surgical training during the pandemic. The senior management team, with faculty and administrative support, have done a remarkable job in preparing the campus for the September reopening, which at the time of this recording has been relatively smooth. However, like so many countries, Ireland is now experiencing a second surge in COVID cases. I believe we've learnt many lessons from earlier in the year and that we will cope better. Nonetheless, the pandemic has exposed many shortcomings in healthcare systems around the world, with capacity and equity of access being chief amongst them. Perhaps a second positive from the pandemic is that we all now have the opportunity to reprioritize and press the reset button for a better, more equitable and healthier society. The college continues its surgical mission in Ireland and overseas. In July, we were delighted to welcome Mark Shrime as the inaugural O'Brien Chair of Global Surgery. Mark, an ENT, head and neck surgeon from Boston, brings a reputation as one of the leaders of the Lancet Commission on Global Health. But much more importantly, as you will hear shortly, he also brings vision, energy and ambition to his new role in RCSI. We will also hear from my longtime friends, Professors Vivian McAlister from London, Ontario, and Conor Delaney, Chief of the Digestive Disease and Surgery Institute at Cleveland Clinic. I will be speaking with Dr. Majella Doyle, HPB and transplant surgeon at WashU St. Louis. Council member Dr. Margaret O'Donnell will interview Dr. Ruth Tevlin, my former SHO, who is now a resident in plastic surgery at Stanford, and the Vice President, Professor Laura Vianney, will interview Mr. Jaime Doody, who is doing an ENT fellowship in North Carolina. We will finish with a chat with Professor Keith Lillemoe, Surgeon-in-Chief at Massachusetts General Hospital and editor of the Annals of Surgery, who has had a long association with Irish surgeons, particularly those who trained with him at Johns Hopkins before his later moves to Indiana and Boston. But first, we will hear from Professor Mark Shrime.
Good evening. Thank you for the opportunity to speak with you all this evening. My name is Mark. I'm the newly appointed chair of global surgery here at RCSI. And the president has asked me to discuss where we as RCSI can move forward in the field of global surgery. What can the Institute of Global Surgery do in the future? And to do this, I want to introduce you to a patient. A lot of you know that I like to root everything that I do in the stories of patients. So some of you who've heard me speak may have met this patient before. His name is Sambani. He is a rice farmer from the southern part of Madagascar, and he has had this tumor growing out the left side of his face for 30 years. The tumor has taken out movement in his left marginal mandibular nerve. But I don't want to focus on the tumor itself. I want to focus on the story behind the tumor. Because in 30 years, somebody went to 10 different hospitals. Only 3 of them had surgeons in them. None of them would offer him a procedure. He finally had his procedure with an NGO and one of my colleagues on the east coast of Madagascar. So to make the trip from the south to the east meant that he had to be carried on somebody's back for 2 days just to get to the nearest road. And then it was a 6-hour trip up the road to get to the hospital. And although that NGO offers surgery for free, the surgery, the postoperative care, the medications, all at no cost to somebody, to make that 2.5-day trip, to pay for it, this rice farmer had to sell his rice farm. And I think Sambani serves as a really good holistic incarnation of all of the issues that we in the global surgery space try to deal with, all of the barriers that he has to overcome to get his surgery, barriers that we can divide into demand-side barriers, so patient-side barriers, and supply-side or system-side barriers. Demand-side barriers like cost, distance, or transportation, or a lack of knowledge that surgery is available to treat the condition that you have. Supply-side barriers like a lack of providers, a lack of infrastructure, fear about quality or safety of the surgery that you would get. And straddling both of these are governance barriers, such barriers that keep surgery out in the corners while the world focuses on things like infectious disease or bed nets for malaria or nutrition. But when somebody gets his surgery, when we overcome these barriers, we have outcomes from overcoming these barriers that are also patient-centered and system-centered. On the patient side, you've got the simple outcomes of, did the surgery happen? Did the patient survive his surgery? Was the tumor removed? Were there complications, surgical site infections, sort of these first-level outcomes that a lot of us think about when it comes to surgery. But also there are second-level outcomes that the patients think are very important. Things like, are we able to return to work? Do we have to sell our rice farm to get surgery? Is there social isolation before the surgery, and does it still exist afterwards? And then on the system side, overcoming the supply side barriers gives you things like an increase in the number of surgeries, an increase in the number of surgically trained providers, MD level and otherwise, increase in the number of hospitals. Places that we at RCSI have done a lot of work. And then overcoming the governance barrier gives you things like national surgical, obstetric, and anesthetic plans, where a lot of the global surgery conversation is right now. So as I was thinking about what the best way is for us at RCSI to move forward to improve surgical access in resource-constrained settings, I wanted to build on the very solid foundation that we have. One of the reasons that I was interested in this job is because of the solid foundation. A 13-year collaboration between RCSI and the College of Surgeons of East, Central, and Southern Africa that has led to the training of hundreds of COSEXA surgeons. Work around implementation science and patient-centered care with Rory Brua and now Kuba Gajewski through COST Africa and Surge Africa. But I also wanted to look at the global surgery landscape writ large. Where are our collaborators working? Collaborators like Birmingham, the best funded global surgery unit in the world right now, or like Lund and Harvard, who are official WHO collaborating centers around workforce development and training, or around development of national surgical plans. And when you take an overview of the global surgery landscape, you see that these organizations work very much in silos. You've got a lot of people working in those first level outcomes of surgery, SSI, mortality, et cetera. You've got a lot of people, including a WHO collaborating center in the development of surgical workforce, a WHO collaborating center and others working in the development of national surgical, obstetric, and anesthetic plans. And the reason that I went through this boils down to one of my favorite proverbs. It's a Kenyan proverb that says, all monkeys cannot hang on the same branch. So to develop our plan and strategy for the next 3 to 5 years, I wanted to focus on the branch that we are hanging on, that we have expertise in, and make sure that we aren't trying to hang on the same branch as everybody else. So let's take out the branches that our colleagues are working in. And what you have left are the things that we have developed expertise in. We have a niche in the global surgery space that we can push going forward, which brings me to the vision for the Institute of Global Surgery in the next 3 to 5 years, building on over a decade of experience in surgical training, education, and research partnerships in sub-Saharan Africa. The Institute of Global Surgery will have this vision for the next 3 to 5 years, that rooted in equity and in collaboration with partners, we will create patient-centered, outcomes-based global surgery research and education. And we will expand our collaborations, not abandoning COSEXA, but in addition to COSEXA, we will expand our collaboration such that we incorporate global surgery education across the life course of an RCSI trainee and RCSI surgeon, and expand our collaborations to areas outside of East Africa where our funding partners have priorities, places like Southeast Asia, places like West Africa. Because as surgeons, we're really good at doing surgery. As surgeons, we're really good at those first level outcomes. We're really good at taking this tumor off, bringing somebody from his pre to his post-operative pictures. But if we really want to move forward in advancing the field of global surgery as RCSI, I think this is an opportunity for us to take a step back and look at the entire picture of Sambani's story and start treating that picture holistically. Thank you very much.
Well, it's a real pleasure to introduce my old friend, classmate, Vivian McAlister, who's Professor of Surgery at the University of Western Ontario in London, Ontario. Vivian, as you can see, wearing the college tie, is a fellow of the Irish College. I'm sure you had to hunt high and low to find that, Vivian, for today, but you're very welcome.
It's great to have an opportunity to wear a tie, Ronan, and especially to wear the college tie. I think the last time might have been February, but anyway, that has been released. As
you know, we would normally meet at the ACS meeting, and unfortunately the fellows and members reception, which we would have got together, is cancelled this year. So we're going virtually, which is a great opportunity to meet up with old friends and to have a little chat. And of course, COVID-19 has impacted on all of us. How have you fared in Western Ontario?
I think overall we've done very well in comparison to close neighbors such as Detroit and Michigan, and even in comparison to Toronto. You know, life is disrupted. At the very beginning, I was at a meeting in Toronto and they somebody asked me, what did you think about the outbreak in China? And I said, no, they have it under control. I'm amazed at how well they've controlled the thing. Of course, totally naive of what was to happen. And my next experience with it was when a friend called me up and said, would you join a team to set up a field hospital? And I said, a field hospital? Holy smokes. And then the news came in about what was happening down in Detroit. At that time, they were seeing so many people and so many medical staff were actually going down with it. There was a fear of a complete collapse of the medical system. And then I realized that really everybody's looking at the wrong thing with COVID. Deaths, sad as they are, will not be a number that will be remembered greatly. But what is remembered is the destruction of the healthcare system that occurs when an outbreak gets out of hand. So that was how it was. And then Western Ontario was very lucky. There were I believe, two things that brought this about. One was that the US was ahead of us in terms of exposure. And the second was that St. Patrick's Day was coming up. And they were terrified of what could happen with St. Patrick's Day, and that forced the government's hand. Everything shut down in time to stop celebrations occurring on St. Patrick's Day. And actually, we would have had a very different outcome if we didn't have the shutdown in time for that. So we can thank St. Patrick for saving Canada.
Your special interest, of course, is in transplantation, and these are very vulnerable patients. How has that been affected?
So we immediately met about it and decided life-saving transplants should go on. I actually voted that I considered kidney transplantation life-saving and we shouldn't waste good organs. But in actual fact, we stopped kidney transplantation. We continued with liver transplantation. We also continued with emergency general surgery, as everybody did. So I was involved in both of those things. So in fact, my work slowed down, but I continued working throughout the pandemic. And then we gradually reintroduced kidney transplantation, and we're back to normal surgical activity and trying to play catch up.
And have you created a separate pathway within the hospital, a COVID red type pathway and a non-COVID green type pathway?
Yes, we had those zones. So with respect to transplantation, because these are patients coming in, we decided that both the donor and the recipient had to be proven COVID negative. And at the initial outset of that, we said within 24 hours, and then occasionally we'd slip outside our 24-hour restriction with the tests and caused a lot of heartache. But that's how we did that then, and we had known they were COVID negative. We also were doing COVID testing on all our emergency surgery patients, and that switched to going to just screening with questions and testing only as required. But we kind of move back and forth between those requirements. And I actually get confused what's in operation at the time. I leave it to others and tell me it's okay.
Are there any positives that you see? I mean, looking forward, having had this experience, do you think there are any positive things to take from COVID?
Oh, lots of lessons learned and lots of opportunities for change in the future. I'll start about maybe our own generation and direct experience. A lot of us are slowing down, and I think it forced some to take on retirement, and this has opened up some jobs for others. At the same time, team approach to care has been solidified. So I can see us, I don't necessarily call it job sharing, but there will be more places for surgeons in hospitals, and the days of working 36 hours without a break are over. So these are changes where I think the new generation, who never wanted to take on the lifestyle that we had, when we were younger. I think the pandemic will be remembered for pushing these changes through. Telemedicine is definitely here, and a lot more practical approaches to patient-centered care, what works, and what the patients need and want themselves. So having a patient here come maybe 100 miles, wait 2 or 3 hours to come and see me, and then all I do is shake their hand and send them away again, that's not going to happen anymore. However, on the other hand, if I do need to see somebody, the waiting time is now much shorter. I see them immediately, get it done, and try and get all their appointments at the same time so they have a single visit to the hospital. So again, all of those things are good developments that we can apply outside the pandemic as well.
Vivian, I'm really grateful to you for joining with us. Hopefully we'll meet in person in the not too distant future. And our very best to Christiane and the family, and thank you.
Thank you very much, Ronan. Good luck to the college and to you. With your leadership, I know you'll come through this and actually have a stronger institution as a consequence. Thank you.
Hi, Ruth. How are you?
I'm well, thank you.
Lovely to be able to speak to you today, even given the time differences. I know you're in Stanford and in a whole different world from when we last met. I remember meeting you a number of years ago here back in Ireland, but also at one of the American Society meetings in Boston a few years ago. Maybe you'd fill us in. You qualified from UCD in 2009, probably seems a long time ago. So maybe could you fill us in just on what you've been doing since then?
Sure, yeah, it's my pleasure. So yes, as mentioned, I graduated in 2009 from UCD and did a fantastic intern year in Vincent's. At the time, actually, I was one of Professor O'Connell's interns and certainly learned a lot during that time. And then I continued on after a year in Australia. I came back to Ireland and started on the basic surgical training scheme in general surgery. And then during a stint of 6 months in the Mater Hospital, fell in love with plastic surgery, actually, due to a combined case for external wound reconstruction. After that time, I was very fortunate to get an introduction with Dr. Michael Longacre here at Stanford University, who is a world-renowned plastic surgeon who really established the lack of scarring in fetal wounds. And that was how he kind of started his surgical practice. So after that time, initially came back to Ireland and took my USMLEs after 2 years and completing an MD research degree. And then I was very fortunate to match back at Stanford University in the independent, in the integrated track for plastic surgery residency. So that means it's a 7-year program where you run seamlessly through initially the core year and a half or so of general surgery, then into plastic surgery training, and with an inbuilt further year of professional development.
And you have another 2-3 years to go on the program?
Yeah, so another 3 years. So now heading into the final kind of the chief years as such, we have an amazing wealth of opportunities in terms of microsurgical reconstruction, craniofacial and peds, as well as general reconstruction and burn surgery also. So it's a very well-worn path. The residency here is the oldest integrated residency program in America. So it was the first one that actually stopped the division between general surgery and plastic surgery and actually tried to integrate it throughout the program. And so I'm very proud and very fortunate to be here receiving this wonderful training.
Tell me, in the work you're doing at the moment, your training seems to be going really apace and at a great, making great progression. But how has COVID affected your daily work and maybe the research and, you know, the career pathways of people around you?
Sure. In terms of our daily work, back in March, we here in Santa Clara went into a very early shelter in place. And so all elective surgery was initially, put on hold for that period. However, emergency surgery and then oncological surgery and reconstruction did continue. There was a lot of apprehension and anxiety, really, which was fueled by a lack of information. And so I think as we got more and more information, people felt more comfortable, and it wasn't as intimidating as such in the hospital. From the point of view of our initial resident education, all of our education did switch completely to a virtual format. So instead of our weekly meetings in person, which are a great time for us all to get together as residents, as we cover multiple different sites. It's a great time for camaraderie and just checking in with everyone. Mm-hmm. And so unfortunately now that's all on a virtual format. However, the program also put in place visiting lectureship. And so with those additional grand rounds, we had 2 additional grand rounds per week on top of our standard grand rounds teaching, just to give more education during the time. And I think that in a way was just kind of a little bit of a bright light in the week too. And really, I think that as I at the time was the chief resident at the burn unit, mm-hmm. We're obviously, it was an intensive care setting. There was a lot of anxiety as to whether we would also become a COVID unit. Mm-hmm. And having had the first cases in California and had the first deaths in California also in the area, people were understandably very worried in work, and that includes my resident colleagues and nursing colleagues across the board. We did split into a 2-team kind of system where we had Team A in the hospital, Team B on backup at home, just so that if someone were to get unwell, that obviously then the whole service would not be eradicated, because of course burns continued during COVID.
I was going to ask that. Yeah, did you notice a difference, or was it because everybody was at home that you got more of the domestic burns?
That's interesting you say that, Margaret. Yeah, certainly in the first month we had a lot of burns from kind of contact burns from people cooking, and then also a lot of scald burns in children just from people using steam inhalation, which with some education hopefully it didn't really continue, but yeah, certainly we did see a lot of smaller burns initially, but throughout that time we also had major burns coming in. And with the area and the population that's served by the hospital, it's a lot of the underserved populations of Silicon Valley. Yeah. So there was a lot of effort put into utilizing tests appropriately for the correct patients who are high risk. And then obviously the conscious decisions and more emphasis that we had to place ourselves on PPE, and without rushing into someone in a trauma bay, you had to make sure you were appropriately gowned to not increase your own risk, or indeed that for your loved ones at home.
Can you see any silver linings in this? Can you see any benefits coming out of the whole effect of the pandemic that's had either on you personally or then maybe the hospital?
Certainly, I think the camaraderie between different departments has been, really very touching during the pandemic, of people making sure everyone had appropriate PPE and that they were aware that this patient was high risk before entering a room, and really seeing how everyone looked after each other. And then also from the point of view of education, for the multiple webinars that have been set up here and teaching rounds, which are being held virtually. So the American Society of Plastic Surgery set up an amazing teaching series for us with thought leaders and all kind of different subspecialties, in addition to our kind of faculty at the Bunkie Clinic also, who also set up an amazing array of presenters from all around the world. And so I think that having that access to education and that being disseminated so easily, that was something I always loved when I was at home in Ireland, going away to conferences and hearing experts speak about new techniques, whereas now it can easily come through your computer. And I think that is really something that has kind of been very innovative and very special. Yeah.
Well, hopefully we'll be able to travel soon and maybe meet again one of the American Society of Plastic Surgery meetings or something similar. Ruth, it's been an absolute pleasure talking to you. You have an amazing career behind you, but I can't believe it's going to be anything but stellar ahead of you. So the best of luck with everything in the future.
Thank
Bye-bye.
you very much. It was great to speak with you. Thanks for being included.
Okay, bye-bye.
Bye.
Well, our next alumnus is Dr. Majella Doyle. Majella, it's a long time since we worked together. I think it was in the Mater in the mid-90s. When did you move to the States?
I moved to the States in 2005, and yes, I have extremely fond memories of working that busy SHO job with yourself and Mr. McEntee in the Mater Hospital.
I'm sure I was the easier taskmaster. I don't think Jerry.
Of course.
So now you've risen to great heights. You're head of liver transplantation at Children's in WashU at St. Louis, and also vice chair of the Department of Surgery. These are onerous responsibilities in the current environment.
Yeah. Well, I'm vice chair of clinical operations now in the Department of Surgery. Not quite the vice chair, but it's certainly busy. And I have a busy practice in transplantation, abdominal transplantation, along with a busy cancer practice in hepatobiliary surgery. So it certainly keeps me busy over here.
How did COVID impact on your practice?
Well, initially it was kind of crazy. We were at our annual meeting in Miami, and some of our New York colleagues had been banned from travel, and we were sort of all reeling as to what was going on. I think the cases in New York were just building. It was right at the beginning of March, and over the 3 or 4 days of the meeting, it became apparent that this was incredibly serious. And so we all were sort of, anxious to get home. And of course, that was the last meeting we've been at, because everything has either gone to virtual or has been cancelled since. Our institution quickly put in a travel ban. We weren't allowed to go anywhere outside of 60 miles, and certainly no travel to meetings or anything like that. And we pretty much stopped operating within a week or two of the New York impact. And all our patients were categorized, not just in transplant, but across the department, according to the ACS guidelines, tier 3 down to tier 1. And as a result, many of the transplant patients were in the high tiers. And so we were continuing business as usual.
So what's good about the new normal? What benefits are there?
I think from the patient perspective, one of the huge innovations that we've been talking about and trying to do for a while, but really was rushed in, is telehealth and telemedicine. So for patients, particularly here, they travel from so far sometimes to come see us. It's such a luxury for them to be able to see us and have access to us easily in person by Zoom. And there's no comparison to a phone call, I think, to being able to see them face to face. And so I think the patients love it.
Well, I don't know about you. I don't miss the travel, but I miss arriving because at the end of it all, there's good friends and colleagues and indeed family at the end of the travel. Yeah. What do you see is the future of American College meeting and other meetings like this?
There's such a divide between virtual meetings and where we're going. So are cancelling meetings. We've had several meetings cancelled. We have several meetings virtual. We know the ACS is going to be coming up here now virtual. I was participating in a meeting hosted in South America last weekend, and there were 1,700 participants on the call, which was absolutely incredible. And because I was on an international meeting the week before, and there had been far less participants. So I think it's very variable as to the level of participation. I do think when you have a virtual component to the meeting, it's going to deter some people from traveling. But I think we're all just looking forward to having the opportunity to go and see each other again, because it's a huge challenge missing the connection and the networking with your colleagues.
Sure. Well, we sincerely hope you'll have the opportunity to meet all the Doyles back home in the not too distant future.
I know it's been on a personal level, it's been very challenging being over here and being away. But I know it's shared throughout the nation, because whether your family is overseas or whether your family is in a different part of the country, it's been challenging to go and see for everybody. So But I look forward to being home soon.
Well, Majella, I hope you'll drop by the college and say hello. Thank you very much indeed.
Thank you.
Good morning, Jaime. It's a great opportunity to talk with you today. And first of all, I'd like to say I hope you and your family and colleagues are all well.
Thank you very much.
So Jaime, you're a Trinity College graduate, as I am myself.
Mm-hmm.
You're an RCSI otolaryngology trainee in the past, and you're also an RCSI Ethicon fellow. And during your fellowship, you went to Boston Children's Hospital, which must have been a great experience.
No, I was during my fellowship year in Boston. I was just entertaining, kind of going anywhere really, which is kind of the good thing about my fellowship at the Royal College of Surgeons, and also my Trinity degrees, that they travel pretty well. So when I was in Boston, just people just started giving me offers, and I interviewed in a few institutions in the United States. And North Carolina kind of had the right mix of complexity and academia that I wanted going forward. So I ended up here. It's a great practice. I think it's very good practice for a kind of a fresh consultant or attending, because I've got a lot of senior colleagues here that are very eager and willing to help. My practice here is that I'm part of a department of otolaryngology in UNC, which comprises of about 26 surgeons, divided up. Yeah, it's crazy, right? I mean, it's when you think about the scale of it compared to, Ireland, which has 40, 50 is, attendings or consultants nationally. So it's divided up into various divisions, skull base and rhinology, facial plastics, head and neck, laryngology, and then pediatric ENT. So I'm in the pediatric ENT division. So my practice comprises of 9 to 5, I see just children, and then I cover adult calls sometimes.
I see your lead position now in the first pediatric only satellite clinic in Raleigh. That must be very interesting.
Yeah, obviously America is a completely different world to I mean, like it's just the setup of the medical system here is just completely different. So
great opportunities.
It is. It's a great opportunity. It's pluses and minuses, right? So I know we're going to circle back to COVID later, but each hospital is independent, and each training program is independent, which is good, but it's also bad because it means you lack a kind of concerted unilateral approach towards like global problems.
Are you doing a lot of tracheal reconstruction?
Yeah, well, obviously the pandemic put a kibosh on a lot of airway stuff because I'm sure COVID is an airborne pathogen, so we've severely curtailed. Well, initially we did severely curtail any kind of unnecessary airway work because obviously the aerosol generating procedure aspect of it. But I've done we're proceeding with some LTRs at the moment. So our latest LTR was about 3 weeks ago, and it went well.
I know you had a child, I think it was this week or last week, that had multiple comorbidities. How did that case go in the COVID area? It must have been very difficult to deal with that.
So that child actually had COVID. So this is a tracheostomy we did on a very complicated child. And this child actually had multiple cerebral palsy and a lot of other difficulties. But they contracted COVID about 4 weeks ago. And COVID positive. So we treated the case as a COVID positive case, even though they're probably beyond the infective period. We took full precautions as if they were COVID. Because of course testing will be inconclusive right now, given the fact that they were exposed. Won't tell you a whole lot, but they needed their tracheostomy as they were on event and they weren't going anywhere fast.
Are many of your children turning up with COVID now?
Yes. So our policy is to all elective cases get a COVID test pre-op within 48 hours of surgery. So we are proceeding with elective surgery. That we've changed the priority, so they are kind of priority electives, but they're all getting COVID testing pre-op. And I've had 4 asymptomatic children test positive for COVID that were coming in for tonsillectomy, adenoidectomy for just mild moderate OSA. So I've had 4 positive tests in my practice, and I know my colleagues in the pediatric division have at least 4 or 5 each of asymptomatic children testing positive for COVID.
What about trainees? Will you get involved in training young people? Will we be able to send people from Ireland to you?
Yeah, so I'm working on. I mean, so we have a pediatric fellowship program here,
Excellent.
And it's a program that is an excellent program because within our so we have 6 surgeons. We cover cleft repairs, and we do cochlear implant, all within the division. So I think this program offers a lot to Irish trainees, and it's something that we're certainly discussing at a departmental level here. And I think, but that's part of the beauty of having people that kind of leave Ireland, is that you do kind of create a bit of a trail behind you that people can kind of follow and take advantage of.
Well, listen, thank you very much for talking this morning. I hope maybe sometime over the next few years I'll get the opportunity to visit you.
Yes.
And hopefully we'll see you back in Ireland. And we're very proud of your new position, and good luck for the future. So thank you very much for taking the call this morning.
Thank you, Professor Vivian. And just thank you. Obviously, the Royal College of Surgeons is where I learned how to be an ENT surgeon, and it equipped me, and it gave me the skills necessary to attain a position over here. And I'll always be grateful to the Royal College of Surgeons for what they did for me personally as well. So thank you so much, and thank you for speaking to me today.
You're most welcome.
I'm delighted to welcome Professor Conor Delaney, who is one of our own and currently chairman of the Digestive Diseases Institute at the Cleveland Clinic, Ohio. But good news, he's just been appointed CEO and president of the Cleveland Clinic organization in Florida. Conor, many congratulations.
Ronan, thank you very much. Appreciate it. And it's a pleasure to be with you here today and have a conversation.
Conor, you talked to us earlier in the year about the initial effect of COVID at the Cleveland Clinic and how you coped with it. But I'm interested to hear now how you're adapting to the second wave.
Right. So we've had a very different experience at all of the different hospitals and different regions, whether it's Ohio, Florida, Nevada, whichever, and also based on specialty, and then based on main campus versus the region. So initially we worked fast to come up with criteria for what surgery could be done. And we worked on protocols like everybody else, masks, spacing, social criteria. And we very quickly integrated a testing program. We set up testing here, PCR-based testing, very early. And so then we used that and integrated that with pathways so that patients coming in for surgery with anesthetic would be tested within 24 to 72 hours before surgery. And then patients having outpatient care don't get tested, or outpatient endoscopy off a surgical site. Once patients are co-located, they all get tested, and it's treated almost as if it's a bubble for that day. And then we did a lot of work around caregivers and caregiver support, because even with everything that was being done to protect them from the disease, there was obviously a lot of stress for caregivers. So hardship fund set up, a lot of psychological support put together, counseling, stress-related services, childcare services. And so they were the first few weeks of trying to adapt and getting into what our new normal was.
I know you're familiar with our system in Ireland, and we now have the winter care plan, where the idea is that we need to find another 1,500, 2,000 beds and staff them. What would be your advice to us coming from your perspective?
Yeah, so it's interesting. So the recovery and going into winter phases are really interesting conversations. As regards beds specifically, I think we've certainly, most facilities in the US now have got over the capacity constraints of bed utilization. And it's largely not because there's necessarily a huge number more beds per capita. We probably do for ICU, certainly here within the clinic. I think we've got 450 in Ohio, so that gives us a good buffer for ICU, and we haven't reached that. But for the hospital beds, which can become a pressure point with surges, the way we've managed it for decades now really is with care pathways and very careful focus on length of stay. So people come in and a lot of it's pre-hospital education, and if people are coming in through the emergency room for other reasons, it's in-hospital education. It's having nurses on board, physicians on board, care pathways and order sets on board. And it's around the old stuff we published 20 years ago on Fast Track, or now Enhanced Recovery. And we do similar things with all the medical care pathways. And so it comes down to managing length of stay And so obviously if you have somebody who stays 7 days versus 2 people who stay 3.5 days, that doubles your bed capacity. And so institutions in the US manage it through very carefully focusing on length of stay.
And what are your big ambitions for the Cleveland Clinic in Florida now that you're moving south?
Yeah, so it's really exciting. We have a fantastic team there, and people are most familiar with the Weston campus, which was the primary campus there. Over the last few years, we've actually extended north, so we now have 5 hospitals on the east side of Florida. And the ambitions are, just to scale the group there. We have a lot of talent. We'll build subspecialties throughout the region, and then we're expanding. We'll be a larger system in the near future. And so the excitement is the opportunity really to bring the Cleveland Clinic care pathways and practices to a larger number of patients, because that's been our mission across the organization.
We might have to get you to extend them out to the HSE at home.
Well, there is good direct flight access to Fort Lauderdale and Miami, so we'll help if we can.
Conor, as you know, RCSI has the Medical University of Bahrain, and Bahrain has been affected, as all of the Middle East and the Gulf region. How have your experiences in Cleveland Clinic in Abu Dhabi been?
Yeah, so we've had, I mentioned a little Florida versus Ohio in US experiences. So we've also got feedback from our teams in London and Abu Dhabi. Abu Dhabi, so one of the really fantastic things about the clinic as an enterprise and being a global enterprise is that we're learning different things from different groups in different places. And Abu Dhabi were a little ahead of us in the speed of their first surge. So we shared ICU protocols. A lot of the people over there have been here, so we have very close relationships. And now we're going to be learning from them about vaccine programs. It looks like, I'm not sure it's final yet, but it looks like Abu Dhabi will be using the Chinese vaccine sooner. So we'll learn about integration of that. Once they got over the initial surge, though, they got into a very stable place. So not as high a surge. They had it, they managed it, we learned from it, and now they're going to be earlier in the vaccine phase, and so we hope to learn from that too.
Good. Conor, thank you so much for taking time this morning to join with us. I'm sorry it's virtual, and I hope that we'll meet at the ACS next year in San Diego.
I look forward to it, Ronan. Thank you very much for the opportunity.
Thank you, Conor. It's a great pleasure to welcome Dr. Keith Lillemoe, who, as many of you know, is Surgeon-in-Chief at the Massachusetts General Hospital and also Professor of Surgery at Harvard Medical School. Keith is also Editor-in-Chief of the Annals of Surgery, and I guess it's through the Annals of Surgery that he and I met, and through the European Surgical and the American Surgical, of which he's a past president.
Well, Ronan, thank you for the invitation to connect with all our friends in the Ireland organization. Friendships that have gone back for me to the days of a resident at Hopkins when we used to have an exchange with the Royal College of Surgeons of Ireland. But it's always a pleasure to see your group. We hosted you in Boston not too many years ago, and so I'm happy to be part of this. COVID for Annals of Surgery is, I guess the best word to say is be careful what you ask for. When COVID started coming out and there was a lot of publications starting to show up in the medical literature, we realized that it was a surgical problem as well, not just in the risk to surgeons in the hospital environment, but issues in taking care of COVID patients safely and running our practices safely and efficiently. So we sort of did this sort of call for submissions, and that's what I mean, be careful what you ask for, but that really turned on the floodgates. I think at our last count, we're probably close to 700 COVID-related papers submitted since March, and we've accepted and published about 100. That works out to be about 14% of the papers that come in. Now, fortunately for the review process, most of them in the early stages were brief clinical reports or surgical opinions or surgical perspectives, which were limited in terms of the number of words and the number of figures. And so it was a lot of work. And I have to say that like many of the leaders, most of my time during COVID, I wasn't operating. I wasn't going to the meetings. There was no sports for me to watch. And so I was pretty committed to making this work. So I took a lot of it on myself, but we had great associate editors that did several of them in certain niches. And the review process went pretty smoothly. Fortunately, our publisher was very generous in putting them all online on the website, open access. I would say the papers were a mixture of sort of early surgical experience, some opinion pieces about topics from everything from aerosolization of COVID during laparoscopic procedures, also a management of cases as you're decreasing and how to control the cases that you do. And then as COVID, at least in parts of the country, sort of went down, how you open back up to normal activity, telemedicine, virtual interviews for our residency and fellowship processes, education. We covered the whole gamut of topics.
We're now facing a second surge here in Ireland. We've partially closed Dublin down, actually, again. How are you doing on the East Coast of the States?
Well, the United States, again, the East Coast, particularly New York, New Jersey, Massachusetts, got hit pretty hard in that first wave, probably 2 to 3 weeks behind Europe, maybe a little further behind Italy, but the rest of Europe, we were a little bit behind. And I think, it's a big political issue. We might have closed down better than we could have done a better job of closing down. But the bottom line is, since it's gone down, and I guess the numbers probably would be in late May, we sort of went down. We have not seen a surge yet in Massachusetts. Now, Massachusetts is a big college town. And so as kids are coming back to go to college, the numbers have gone up in terms of testing, which obviously the schools are requiring them to test. But in terms of the number of patients in the hospital and sick patients, I think the numbers have stayed pretty low.
Keith, apart from the effects on surgery itself, COVID, I think, exposed some issues about equality and access and diversity. Would you like to explore that?
Yes, Ronan, I'm pleased again to say, when the COVID started going down and we were being a little bit more selective about the manuscripts that we were giving full review to, was about the time our country really got caught up with a lot of problems related to social injustice, equity, diversity. And then even more recently, there's been this surge of concern about diversity and inclusion in the editorial review process with respect to a membership on editorial boards, access to being writing editorials for feature articles, things along those lines. And there has been a call for action by the Surgical Editors Group that has addressed this. And so Annals sort of, again, I didn't learn from COVID. I sort of turned our attention to looking to accept and fast track and publish papers that we felt were important related to diversity and inclusion. And we've had a couple of very important statements, one from the American Surgical Association, one from Annals related to the process that I think is, again, showing that we recognize the problem and we're going to do what we can as a journal to not only publish papers, well-done papers on these topics, again, make them open access on the website, as well as look at the diversity of our editorial board and other aspects. And I think we do a good job from the perspective of gender, but like in many things in our country and in our specialty, I think in having racial diversity, we still have a long ways to go.
Keith, we really do appreciate you taking time out of your busy day. And I'm sorry that you can't visit us as a group in Chicago. And I'm very sorry I can't join you at the Massachusetts General Fellows and Alumni gathering as well. So
that was a great social event to see everyone. And I look forward to hopefully by October 21, we'll be back to a new normal and getting together.
I look forward to it. Keith, thank you so much.
Thank you, Ronan.
I hope you have found this evening's get-together interesting and that it has given you a real sense of the strong connections between the surgical fraternity in Ireland and our friends and colleagues in North America. I'm very grateful to our contributors, to Vice President Laura Vianney, Council Member Margaret O'Donnell, and most of all to Robin Burt, our Fellows and Members Manager, who arranged everything. I hope that we will be able to meet in person at the ACS Clinical Congress in San Diego this time next year. And in the meantime, keep safe and keep in touch.